Let us understand the two concepts: thyrotoxicosis, which is the state of too much hormone, and hyperthyroidism, which is the cause of overactive gland. Major causes of hypothyroidism includes Graves' disease, toxic multinodular goiter, and toxic adenomas. To confirm the diagnosis of hyperthyroidism, we do the blood tests. Hyperthyroidism is confirmed by low, undetectable TSH and elevated free T3 and T4. Also, ultrasound of the neck or a thyroid scan done. Symptoms of hyperthyroidism includes feeling hyperactive, irritable, anxious, or having sudden mood swings, intense heat intolerance and excessive sweating, persistent fatigue and generalized muscle weakness, significant weight loss even though you are eating more than usual, palpitations, the feeling of your heart pounding or skipping a beat, diarrhea and needing to urinate more often, that is polyuria, changes in menstrual flow, that is lighter or missed periods, and a loss of interest in sex, that is low libido. Signs of hyperthyroidism includes fast heart rate, that is tachycardia, tremors, that is shaking hands, a visible goiter, that is enlarged neck, and lid lag, where the eyelid doesn't follow the eye correctly when looking down. Treatment of hyperthyroidism includes adjunctive treatment and antithyroid drugs. Adjunctive treatment of hyperthyroidism do not lower thyroid hormone, but block the fight or flight symptoms. Tablet propranolol 40 to 120 mg a day, usually split into 3 or 4 doses. Example, 20 to 40 mg every 8 hours. It is non-selective, meaning it works well on the heart and tremors. Tablet atenolol 25 mg to 50 mg a day. It is cardioselective, making it safer for patients with mild asthma. Antithyroid drugs in treatment of hyperthyroidism are thionamides. These drugs stop the gland from manufacturing new hormones. Tablet propylthiouracil 100 to 150 mg every 6 to 8 hours. This is the starting dose for moderate to severe cases. It has a short half-life, so it must be taken multiple times a day. Or, tablet carbimazole 10 to 20 mg every 8 to 12 hours, because carbimazole is more potent than propylthiouracil. A total daily dose of 30 to 60 mg is used initially to get the disease under control. Once controlled, reduced to the smallest effective dose. This is called titration. Once hormone levels T3-T4 normalize, the dose is dropped to a maintenance level. That is carbimazole 5 to 15 mg daily for 12 to 18 months. Hyperthyroidism in pregnancy is managed as tablet propylthiouracil 200 mg per day is preferred. This drug is preferred in the first trimester because it crosses the placenta less easily and has a lower risk of causing specific birth defects like aplasia cutis compared to carbimazole. If propylthiouracil dose greater than 300 mg per day is required, then surgery is indicated, because high doses of these drugs can cross the placenta and cause the baby to develop a goiter or hypothyroidism. If the mother's disease is so severe she needs more than 300 mg of propylthiouracil, surgery in the second trimester is safer for the baby. Thyrotoxic crisis or thyroid storm management. This is a high mortality emergency. The doses here are much higher to flood the system and stop hormone production immediately. Tablet propylthiouracil 600 mg loading dose, then 200 to 300 mg every 6 hours. This 600 mg dose shuts down the thyroid's ability to process iodine. Propylthiouracil is specifically chosen for storm because it also blocks the conversion of T4 to T3 in the blood. Tablet carbimazole 15 to 25 mg 6 hourly is an alternative if propylthiouracil is unavailable, though it lacks the T4 to T3 blocking effect. Give saturated solution of potassium iodide, that is SSKI5, drops every 5 hours. OR Lugols 10 drops 3 times a day. This must be given 1 hour after the antithyroid drug. If it is given too early, the thyroid will use this extra iodine as fuel to make even more hormone. This given iodine in high doses temporarily paralyzes the thyroid gland, which is called the Wolff-Chaikoff effect. Also give tablet propranolol 40 to 60 mg 4 hourly or 0.5 to 2 mg IV every 4 hours. These high doses are needed to protect the heart from burning out due to the extreme metabolic rate. And injection dexamethasone 2 mg IV 6 hourly. As steroids block the conversion of T4 to T3. They treat relative adrenal insufficiency. Graves' disease is an autoimmune condition and is the most common cause of hyperthyroidism. It is characterized by diffuse goiter. It means the entire thyroid gland is enlarged and typically feels smooth and uniform, rather than lumpy. The immune system causes inflammation in the tissues around the eyes, leading to exophthalmos, that is bulging or protruding eyes. And lid lag means the upper eyelid stays too high when the patient looks downward. And it shows dermopathy known as pretibial myxedema. It is a rare waxy, orange peel thickening of the skin, usually on the shins. Let us understand about toxic multinodular goiter. This is a non-autoimmune condition, usually occurring in older adults, where parts of a pre-existing goiter become overactive. The word toxic indicates that the gland is producing excess hormone. Unlike the smooth gland in Graves', this gland is lumpy multinodular. Unlike Graves', these nodules are permanent physical changes in the gland. They rarely go into remission with drugs, so they are usually destroyed with radioactive iodine. If the lumpy gland grows so large that it presses on the windpipe, causing difficulty in breathing or difficulty swallowing, it must be surgically removed.